Brian Bouch, resuming our conversation about integrative cancer therapies. And we are really in the middle of hearing from you about a series of the specific remedies that you found useful. So where would you take us from here?
I think talking about some of the hormone-related cancers would be as a general topic, and then specifically within that,
Right.
breast, ovarian, prostate, testicular.
Great.
So with breast cancer therapies, I guess most of you at this point know that there are estrogen receptor positive breast cancers, estrogen receptor negative breast cancers, and HER2 new positive breast cancers. And then there's what's called triple negative breast cancers. So those are kind of the four. Well, actually, those are the three biggest, because if they're estrogen negative and they're HER2 negative, then they're and progesterone negative, then they're triple negatives. So what that means is that estrogen has the potential for possibly triggering and accelerating the growth of certain types of breast cancers, not only in women but in men. And although it's hardly ever talked about, there is an incidence of breast cancer in men that comes out to be about 1/100th the incidence of breast cancer in women, and it has all the same implications as it does in women. You've probably seen some men who've come through here through the Cancer Health Program with it. And there are genetic tests now that can sometimes predict the likelihood of a woman getting breast cancer or not. They're not 100% in terms of their accuracy, but there's definitely a strong familial link. If a woman has a mother or a sister who has had breast cancer, then she's at significantly higher risk for developing breast cancer. African American women have higher rates of breast cancer than non-African Americans. And if it's an estrogen receptor, and so what they do when somebody has a breast tumor is the tumor is usually is biopsied, sometimes removed completely at the time of the biopsy, and studied not only for the cell type, which is what all pathology examinations look at, but also to find out if it has the markings of being an estrogen receptor positive cancer, progesterone receptor positive cancer, or another substance in the body called HER2 new, which is a surface marker on the cancer cells. Estrogen receptor positive cancers, besides conventional surgery, chemotherapy, radiation, are often treated with estrogen blocking drugs. And the estrogen blocking drugs, the one that's been around forever, is Tamoxifen. It is effective. It's still used, and the other drugs are. They work in a slightly different pathway, but they have the same ultimate effect of lowering the amount of estrogen in the body that has the potential for making the cancer come back. So the assumption here is that the initial breast cancer is removed. There may not be any other signs of breast cancer in the body, by imaging, by scans, by the blood tests that are used, but there are probably some stray cancer cells somewhere around that can land and then at some point start growing again, and that's what metastatic cancer is when it comes back and starts spreading to other parts of the body, liver, lung, brain, various other organs in the body. If the woman is also treated, or the man is also treated with an estrogen blocking drug for a period of 5 years, seems to be about the average now for these different drugs, it lowers the risk of recurrence of that cancer significantly. The problem has always been that the estrogen blocking drugs have to be taken long term, and they're not free of side effects. So that the issue with tamoxifen has always been that it actually increases the risk for uterine cancer, not by a lot, but by a significant percentage. And it also increases the risk for formation of blood clots in the veins. And then blood clots can be locally uncomfortable, but can also break through and travel to the lungs and cause a pulmonary embolus, which can be a fatal condition. It can be pretty scary. The aromatase inhibitors, which is the other class of estrogen blocking drugs, things like Femara and Aromasin, they work differently. I'm sorry, let's go back to tamoxifen. Tamoxifen is called a SERM, S-E-R-M, which means selective estrogen receptor modulator. And so the tamoxifen acts like a phony estrogen that sits on the estrogen receptors and blocks the uptake of natural estrogen that's coming from the woman's body. So that even though many women are postmenopausal and not producing a lot of estrogen, they're still producing estrogen. And most of it at that point comes from the adrenal gland instead of from the ovary. It comes from adrenal testosterone, which comes from DHEA, and it is converted into estrogen through a pathway called the aromatase pathway. The aromatase inhibitors block this enzyme, aromatase, which is responsible for that conversion, so it keeps it in the form of testosterone. It doesn't get to estrogen, and so the decreased estrogen then downregulates the tendency for cancer cells to grow and to take off again. HER2/neu, which is this other surface protein marker that occurs, is very susceptible to a landmark drug that first showed up, I guess, about 12 years ago called Herceptin. I think many of you have heard of that. And and that's given by intravenous injection. The others are oral treatments. And if Herceptin is given for 1 year after the woman has finished with radiation, chemotherapy, surgery, whatever she's going to go through, and has that type of cancer, it dramatically reduces the risk of it recurring or metastasizing. Couple of other tidbits about breast cancer are that although radiation is, part and parcel of the whole treatment of early stage breast cancer, radiation itself decreases the risk of recurrence of cancer in that breast. It decreases the percentage of recurrence of cancer in the breast only by about 50%, but it does nothing in terms of preventing metastasis or preventing a later recurrence elsewhere in the body. And it's a big price. I mean, radiation is not a walk in the park. I'm sure there are people here who have gone through it. There's a lot of local discomfort. There's a lot of skin burning that can occur. There's fibrosis that can occur, contraction of the tissues. It's a tough road to go through. And so, my take on it has always been that there needs to be really good reason to do radiation. And if there's something that's going to be dropped for an aggressive cancer, if there's something that's going to be dropped out, radiation would be the first thing I would drop out, with surgery and chemotherapy, if the chemotherapy is necessary, being the main ones to keep in. In the last several years, we've seen the advent of genetic testing, which has really changed the field to some degree. The genetic testing does what they call a 23-gene array, and they're actually examining the tumor for different genes that would predict the likelihood of recurrence of the cancer. If somebody has a very low score on one of these gene tests, then it's not likely that chemotherapy is going to be offered because it's probably not going to add much, in terms of benefit. But the chemotherapy also has lots of side effects, as you know. If someone has a very high score on the genetic testing, then you can bet that chemotherapy is going to be recommended as part of the treatment. In terms of let's see if there's anything else I want to say just about I think that's a pretty good look at the overall treatment that goes down with breast cancer. So what did we have to offer specifically in the onc field, as Michael calls it? Because some women were not going to take any of the estrogen blockers because they did not want to deal with the side effects, or because they had started taking them and started experiencing the side effects. The aromatase inhibitors, the main side effect that keeps people, that takes people away from it, is joint pain. There's significant joint pain that occurs in approximately 35 to 40% of women who take aromatase inhibitors. And so that there's a pretty significant dropout rate where people will stop taking it after they've started. And you need to take it for anywhere from 2 to 5 years for it to really be of benefit. So there's another pathway of estrogen metabolism in the body whereby estrone, as the parent estrogen compound, has several different forms: 2-hydroxyestrone, 4-hydroxyestrone, and 16-hydroxyestrone. 2-hydroxyestrone has many of the benefits of estrogen in terms of being essential for normal tissue maturation, growth, and health, but it doesn't stimulate breast cancer cells. 4-hydroxyestrone does, and 16-hydroxyestrone does. And normally there's a conversion of one to the other. So another way of approaching this would be, how do we block the conversion of 2-hydroxyestrone to 16-hydroxyestrone? Well, there is a natural substance in broccoli that does exactly that. It's called diindolylmethane, abbreviated DIM. And it can be taken as an oral supplement. There are mainstream studies on it, but again, because it's not a potential blockbuster drug, we don't have the several $million studies that are going to have the statistical power to convince the rest of the medical community and the oncology community that it's going to be anywhere near as effective. But we've used it for years, both alongside the other estrogen blocking drugs and sometimes, standalone, because someone couldn't tolerate the other estrogen blocking drugs, and we've seen good results with it. So this is diindolylmethane, DIM. Some of you are probably familiar with that. Now, broccoli is a pretty amazing substance, as are some of the other cole family plants. Cabbage, cauliflower, Brussels sprouts, kale, cabbage. They also produce something called sulforaphane, and sulforaphane also has direct cancer preventing effects. And there's another compound in broccoli seeds called glucosinolate, like glucose and then INOLATE. And that one also has a direct anti-cancer effect. It seems, Chris and I were arguing about this on the way over here today. I had thought that sulforaphane and glucosinolates had independent modes of action. Chris thinks that one converts to the other.
But I'm not sure. I haven't had a connection to actually look it up.
Okay. So anyway, maybe we'll get that and get it down for you so it can go on the website once we figure that out. But in any case, it's a really good idea with all cancers to be using broccoli derivatives because of the sulforaphanes. But in the specific case of breast cancer that is estrogen receptor positive, diindolylmethane that's the specific substance that one would want to be taking.
Are you going to change topics now?
No, I'm staying here for a
Are you going to
second.
talk about 2-methoxyestradiol?
I wasn't going to go there, but would you like to jump in and say that?
Well, I just wanted to say that from my work and my research, the most protective compound is after you have the 2-hydroxy, you convert that via a methylation enzyme, catechol methyltransferase, to 2-methoxyestradiol, which actually has anti-carcinogenic, anti-proliferative properties. That's the molecule that, the first stage is 2-hydroxy, that you get there with DIM, diindolylmethane, broccoli, having sufficient iodine and having sufficient selenium. Then you want to do the next step, which is converting the 2-hydroxy to the 2-methoxy. And that is assisted by having sufficient
Methylation.
or extra methyl B12,
Yes.
methylfolate,
Okay,
trimethylglycine. And then with regard to the 4, which is the most, potentially carcinogenic, because it can convert to 3,4-quinone, you can nullify the effect of the 4-hydroxy by the same catechol methyltransferase enzyme, assisted by methyl B12 and methylfolate, and convert that to 4-methoxyestradiol, which is neutralized. It neutralizes the molecule so that it's no longer dangerous.
Great, thank you for that. And Debbie Downer's back. Methyl B12 is potentially on the block along with glutathione.
Oral? I'm good.
Or just IV?
Chris, is it going to be oral and IV, do you know?
They haven't clarified that. I assume the injectable, because they would
Yeah.
have to remove a lot of products if they removed that.
That's horrendous.
Wow.
That is
What
unbelievable.
reason?
Okay.
That's probably.
So, testosterone is not necessarily a bad thing for women. I mean, women have testosterone naturally, it's just that men have a lot more of it. Testosterone is the hormone that is the most responsible for libido, and most people don't want to give that up and actually, often welcome some help in that area, especially as we age. So this idea of blocking the conversion of testosterone to estrogen is not a bad thing. By blocking it, you're actually accumulating a bit more testosterone. Testosterone helps muscle mass, it helps mood, and it helps libido. Let's see. I don't know of any natural substances that are useful in the treatment of HER2 new positive cancer specifically. I think Herceptin's really had that one locked up for a long time. Did I mention calcium D-glucarate before for detox? Okay, so a little bit of gastrointestinal physiology here. One of the main jobs of the liver is to help to get rid of toxic substances in the body, which can also include metabolites of hormones that we've produced. And the liver cells go through their process of sometimes binding the toxins to other substances, and then they secrete it into the bile, which is manufactured in the liver. Bile gets stored in the gallbladder, and then the gallbladder squirts that bile into the intestine under the influence of a meal coming through, especially a fatty meal. The bile, besides containing these toxic substances, also contains, it has an emulsifying property so that it takes fat and it breaks the fat down into microscopic droplets so that the enzymes produced by the pancreas can actually help to digest the fats and allow you to absorb the fats into your system. So bile has this dual mode of action, detoxifying and helping with fat, with fat digestion. Once the bile has gotten into the intestinal tract, sometimes the substances that it's taken down there, including the toxins and some of these breakdown products of the hormones, are reabsorbed from the intestinal tract and get back into the circulation and then keep going around so that we don't really get rid of them. And that's called the enterohepatic recirculation. It's not a great thing if you're trying to get rid of toxins. You want stuff to be taken out and carried out with the stool when you have your next bowel movement. So there are some strategies that have been developed to try to prevent the enterohepatic recirculation from carrying that stuff back into the system instead of getting excreted. And one of them is a substance called calcium D-glucarate, Glucarate. And it's not about the calcium in it. Calcium is just the salt that binds the glucaric acid. And glucaric acid interferes with an enzyme that's responsible for allowing these substances to get reabsorbed into the body. So giving calcium D-glucarate as an over-the-counter supplement in any kind of cancer is good for detoxification, but especially in the, and also for detoxification for people with other conditions that are non-cancer related. It also has this component of being able to reduce the hormone load as well. So if you've got too much estrogen on board and you're trying to get it down naturally, the calcium D-glucarate works for that as well. Okay. Prostate cancer is the other big hormonal cancer that we're in.
Before we go to prostate for
Yeah.
just a sec, because we have more people with breast cancer in the Cancer Health Program than any other cancer, and because women are much more interested in integrative therapies than men, and because breast cancer is the primary reason that women get interested in integrative therapies in general, you've given some specifics on breast cancer, but what is a broader sense of the treatment strategy on breast cancer than the specifics that you gave? And one specific question, and forgive me, I have no medical technical knowledge, but my understanding is that when you, and correct me if I'm wrong, when you look at a tumor, depending on where you slice it, you may get different readings of what a specific cancer is. That may differ from place to place, even in an individual tumor. What about these labs that people send tumor samples to that test the tumor sample against different chemotherapies? Those labs are controversial. Do you find them useful? And if so, which labs do you use and how?
I would have thought that Mark or Keith would have covered this, but I'm happy to talk
Well,
about
but
it
the point
also.
is that these are each separate. In other words, people won't necessarily have watched the other.
Okay.
Yeah.
Sure. So there's an area of investigation called chemosensitivity testing,
Yeah.
with the idea that if you can take somebody's specific tumor cells from a biopsy, keep those cells alive in a tissue culture, and then subject them to various agents to see what prevents the growth of those cells, then it gives you an idea what is likely to work better with that particular patient based on their tumor's response. Than just the general idea, well, the way we got to cisplatin, ACT or CT as being the combination chemotherapy drugs that are used for all breast cancers. This then gives a more specific view of, okay, this is a chemotherapy that's more likely to work, and that one's not as likely to work because it didn't kill the cells in tissue culture. Is that clear?
Yes.
So the labs that we've used historically have been the Wiesenthal Cancer Center in Los Angeles. And to utilize that, the biopsy has to be done in a special way, because traditionally biopsies are done by taking a piece of the tumor, preserving it immediately in formaldehyde, which kills the cells, but also prevents them from degrading, putting them in a microtome, which is a machine that slices them into ultra-thin sections, putting those little thin sections on a microscope slide, staining it with various biological stains, and then reading it. And then the pathologist reads it and says, this is what I see. These are the types of tumor cells that are present. So if somebody's going to have chemosensitivity testing done, they have to have a special transport kit in the operating room ready to receive the cells, and they need to go out within 24 hours, shipped FedEx to either Wiesenthal Cancer Center or Rational Therapeutics in Long Beach, which is run by Dr. Robert Nagorny,
Right.
Nagourney.
And is there a distinction between Wiesenthal and Nagorny, I believe, were originally partners?
Long time ago.
Yeah. Is there a significant distinction between the way Wiesenthal does it and the way Nagorny does it?
There are some differences and there's some overlap. Nagorny is a practicing oncologist with the lab, doing this testing as his a side business. Larry Wiesenthal is a researcher. He's a PhD researcher and not an oncologist, and he's very bright. It was always kind of a toss-up for me as to which one I was going to use. Wiesenthal would be able to check for a few other things than Nagorny would, and vice versa. Rational Therapeutics was a bit more expensive. These tests usually are between $3,000 and $5,000, and so, sometimes cost was a consideration. But I always felt like I got really pretty good information. And what Mark and Renneker and I decided a long time ago is that we actually thought that the tests were more useful in telling you what not to use.
That's what I've heard, that they do a better job of telling you what not to use.
Right, but of the things that look like they work in the test tube, it's not a sure thing, but at least you can eliminate a portion.
Which is a huge deal.
It's a huge deal.
Because, in other words, just to be clear about this, if it doesn't work in the test tube, and that's where it's there's more evidence that it won't work in real life.
Right.
And that means you're not going to do the wrong chemotherapy, which is just a huge deal, you know.
So the question is, why doesn't mainstream oncology embrace this and
Right.
use it? Beats the hell out of me.
Well, there was a period of
Yeah.
time, I actually know this, when chemosensitivity testing was a rising star in mainstream oncology.
Mm-hmm.
And then they decided, for whatever set of reasons, that it wasn't good.
Yeah, and it's that whatever set of reasons
Right.
that I just
Yeah.
never got. Yeah.
But the point is that when we're looking at breast cancer was what brought this thing up, that having the chemosensitivity testing done, and as you said, there may be good reasons if you're going to drop something, and I haven't heard anybody say this so clearly before, to drop the radiation because it only prevents the recurrence in that breast and has no impact on the recurrence elsewhere in the body. So if you have somebody who's trying to minimize the toxicity of treatment, right, and you drop the radiation but keep the chemo, then you really want to be sure, as you can be, that you're getting the right chemo. And therefore, using one of these chemosensitivity testing labs, either Weisenthal or Rational Therapeutics, is a significant thing. So
Agreed.
the other piece of this, which may be completely separate, is would different slices of the tumor, depending on where it was in the tumor, show different things, or would it be consistent throughout?
It usually has to do with a different type of tumor coexisting
I see.
rather than different aspects of the same tumor.
I see.
So for example,
Yeah.
DCIS, which is ductal carcinoma in situ, not uncommonly coexists with lobular or ductal invasive cancer.
I see.
And so you can sometimes in the same specimen see both of those.
I
And,
see.
and it makes treatment more complicated.
Okay. Thank you.
There are some labs out of the country that are doing chemosensitivity testing on blood samples. And what they're looking for is what they call circulating tumor cells. Circulating tumor cells used to be pretty experimental. They're now becoming a little bit more mainstream in a way of looking to see if somebody is at risk for likelihood of recurrence. So in other words, if you see some cells that have broken off from the primary tumor and you manage to find them in the bloodstream, then the person's at higher risk for developing metastasis because eventually those cells are going to land somewhere, and if the conditions are favorable, they're going to start to grow. There's a lab in Greece that people have been using. There is another one in Germany. I have looked at the results. I'm not impressed.
Okay.
I think it's a lot of money being thrown down the drain.
Yeah.
I don't know what your sense on those is, but I haven't been very impressed with those.
There's some here as well that can be done.
Have you seen value?
I haven't run enough of them yet.
Can you speak up a little bit?
Sorry.
Yeah.
I haven't run enough of them yet to comment, but I know at UCSF they are starting to use them now.
The CTCs.
Looking for CTCs,
But
at
they're
least
not
in
doing,
terms of.
but they're not doing chemosensitivity testing.
Right,
Yeah.
right.
Right. So yeah, I think it's very valuable.
Okay. Thank you.
Yes, ma'am.
How does the Econotype follow-up test relate to,
Oncotype is actually.
I mean,
the name of it.
Oncotype, that's what
Yeah,
I'm
it's
saying.
it's the 23 array
That's
gene
what that
analysis.
is.
That's what
Okay,
that
that's
is.
the same thing.
Right, and it comes with a percentage of likelihood of recurrence based on the genes that are seen.
Now, just going to that gene thing for a moment, my understanding, and again it's rudimentary, is that as they start doing the gene testing, they find that a breast cancer or a colon cancer, whatever it is, there may be totally different genotypes, is that what it is? So that a breast cancer and a colon cancer may have more in common than the breast cancer would have with other breast cancers. Is that correct, basically?
Yeah, this is heretical new information.
Right. So the point is, with this heretical new information, and by the way, Medicare is now reimbursing for the genetic testing. Did you know that?
Yeah, I did know that.
Yeah,
With,
which-
with some very specific labs, and they're not my favorite ones necessarily.
Okay, but it's still a
they
big-
they do reimburse for Oncotype, and they have for a few years.
Right.
And that's huge.
So it's a big deal. So the question is, given that a breast cancer, for example, might be from totally different genotypes,
Yeah.
is that the right word? How does that impact chemotherapy choices?
Right now, it doesn't.
But it should, right?
It I think that we'll probably get there, but it's not ready for prime time. It's not happening yet.
But if, for example, just this is me being naive, suppose that one of the genotypes was, say, breast and colon cancer, for example, and there were several chemotherapies for breast cancer and several others for colon cancer. I'm not sure that's a good example. But if it had the colon cancer commonality for a subset of breast cancers, would that provide information that was useful to the choice among breast cancers?
Not among conventional oncologists,
Okay.
but with enough research,
Yeah.
like the kind of Mark and some of the rest of us do, and
Yeah.
Dave Schlosser, that might be able to be discoverable.
I see.
But it's also a place where chemosensitivity testing might have some real usefulness.
Okay, thank you.
Because, and when you look at Larry Weisenthal's results, sometimes he'll come up with a chemotherapy drug being recommended for a tumor type, and usually that chemotherapy is reserved for something completely different. And he'll go,
Right.
no, but this is what we're seeing. So,
And is chemosensitivity testing effective for the circulating cancers?
you mean for blood cancers? I have not had any experience with any of the blood cancers, so I can't answer that. I don't know.
Thank you.
Only solid tumors.
I have to say a word, if it's okay, in defense of estrogen. I hesitate to bring it up because it's such a kind of deep topic, but I do want to say there's only one double-blind placebo-controlled trial that looks at estradiol, topical bioidentical estradiol, and real progesterone, oral progesterone. And in that study, there was no increase in breast cancer. It's just one study. The only other study that I think is pertinent is the Premarin-alone arm of WHI, the Women's Health Initiative study. Women on Premarin alone for 7.2 years had a decreased risk of breast cancer.
It was only, right.
And they were restudied, they're reported out again in 2014, looked at them again. Persistent decrease in breast cancer risk, 23% controlled placebo group.
But increased risk of uterine cancer with estrogen alone.
Well, yeah, so those women all had hysterectomies. We don't
Okay.
give estrogen alone to women
Right.
who have uteruses.
Right.
Absolutely, very good point, right, for sure. But I just want to say that, it's important to keep in mind that estradiol has a tremendous number of anti-inflammatory properties. There's reasons why estradiol could have protective effects in terms of breast cancer. Early pregnancy, which is a very high estrogen state, is protective against breast cancer, right? So there are a lot of reasons to be at least open-minded about this question. Dr. Lyos, who is a breast pathologist specialist who is based in Tiburon, but unfortunately is retiring now, but he has two main themes, and one is that breast cancer overall is often overtreated. DCIS is overtreated. It's kind of, DCIS officially is a pre-cancer, but often there's extreme treatments, etc. The second thing that he believes strongly is that estrogen is not a cause of breast cancer, and that after breast cancer, he believes, as I do, that a year out, it is probably a good idea to do hormone replacement, and gave me 3 papers that show better outcomes for people on hormone replacement in terms of cancer recurrence, in terms of breast cancer recurrence, and in terms of all-cause mortality. So there's many, many questions, I'm sure, inside of this little, amount of information I'm giving here, but I just want to put it on the table.
Thank you
because
for
I
that.
think it's an important thing
Yeah.
to at least consider.
Do you want to comment on that?
No, only that for many women, life without estrogen isn't much fun.
Oh,
They just-
absolutely.
yeah.
Absolutely.
I mean,
And the new
co-
research, the
cognitive
cardiovascular research is that, there is all-cause mortality, strokes, and heart attacks are significantly decreased on estrogen replacement. The longer you're on it, the bigger your decrease in heart attacks, strokes, and all-cause mortality.
Thank
So the cardiology research is tremendous, and of course in the work I'm doing with Alzheimer's, the brain is full of estrogen receptors, and the estradiol has a tremendously trophic effect on the parts of the brain that deteriorate in Alzheimer's disease.
Thank you.
Great, thanks, Ian.
So on to prostate cancer.
Oh, yeah.
And as we start the prostate cancer, let me just preface it with this. We did a wonderful conversation with Dean Ornish, whose work on prostate cancer, as you know, just for those who don't know, Dean Ornish is a colleague who did pioneering research showing that lifestyle therapy actually reversed coronary artery disease. And so he's had a tremendous interest in, it also helps with diabetes and other things, had a tremendous interest in whether this was true of cancer. And so specific cancer he chose was prostate cancer, and he's done controlled clinical trials, and the lifestyle therapies briefly have done well with prostate cancers with a sufficiently low Gleason index. And he just gave a talk on the alternatives in prostate cancer, in which his conclusion, at least, was that if you had a prostate cancer where you could do wait and watch and undertook the lifestyle therapies, that it was, from his point of view, clearly better than the other surgical or radiation interventions. So that's just a little brief state of my knowledge, and I look forward to your wisdom on this.
Actually, could you talk a little bit about the lifestyle therapies that he promoted and used in his studies?
So, as I said, we work with 7 pillars of health. But he would too, but his 4 are diet, stress reduction, exercise, and finding love and support in your life. And so his is a yoga-based program for the stress reduction, and then the diet is a low-fat diet, and then the exercise and social support are more obvious. Now, clearly, there's been a big, this may be what you're getting at, there's been a big fight between Dean and a number of other people on the diet piece of this. And so now some of the functional medicine folks who tend toward the paleo or neo-paleo have really taken him on very directly as to whether a paleo or neo-paleo diet is better than the low-fat diet. And they all defend those positions, is the way I would put it.
That's what I.
Yeah, what?
That's what I.
Yeah.
With my position.
Right.
So, in the same way that we talked about how breast cancer is diagnosed and treated, prostate cancer has a pretty pro forma way of being looked at in this country. The current standard is for a man to after the age of 40, to have an annual digital rectal examination, meaning the doctor puts a finger into the rectum, feels the prostate gland, feels for enlargement and or the presence of any nodules or any asymmetry. In addition to that, a blood test is done called a PSA, which stands for prostate-specific antigen. And PSA most commonly is elevated in the presence of prostate cancer, but it can also be elevated in the presence of a benign enlargement of the prostate, so that it's not specific. But if a PSA test shows up positive, even if the digital exam is normal, if the PSA is high, it's pretty sure that the guy's going to wind up with a biopsy, and they do a transrectal needle biopsy. And then they get the cells out and they look at them, and they have what's called a Gleason Score, Gleeson, with Gleasons down in like the 4-5 range being considered to be indolent, meaning there is cancer present but it doesn't look aggressive. And when the scores get up to 7, 8, or 9, then it's considered to be an aggressive cancer, and more aggressive therapy is called for. So once that happens, the treatment options are radical prostatectomy, which is an operation that's done through an incision in the abdomen, where the prostate gland is isolated, identified, and removed in toto. And they also try to sample a little bit of the tissue around the prostate gland to see if there are any lymph nodes involved. Another treatment mode is to use a series of roughly 40 radiation treatments directed to the prostate gland to completely kill the gland and some of the surrounding tissues. And the other treatment mode that's most commonly available is called radiation seed implant therapy, where they take little granules or seeds of radioactive material and implant them directly into the prostate gland through a needle and leave them in there, and then they give out their radiation over a defined period of time, and that radiation kills the prostate, all the prostate cells. They're not trying to kill just the cancer, they're just going for the whole thing. One other somewhat newer treatment is using high intensity focused ultrasound to kill the prostate cancer and the gland, which is just starting to be accepted in this country as a mainstream treatment. For years, several of the urologists from this country who knew about it would actually take their patients to either Mexico or the Dominican Republic, where they would have a clinic set up where they could provide that treatment outside of the FDA's purview and regulation. But I'm just hearing now that one of the urologists that I know of is now able to do it here. So that's changed. It's a less toxic form of treatment, and from the data that's available, it looks like it's every bit as effective as any of the other kinds. The last analysis that I looked at, which is probably 2 years ago, looking at the effectiveness of the various types of prostate cancer treatment, it did look like there was a slight survival advantage, meaning long-term survival after diagnosis, with the radical prostatectomy operation. But that's also the one that's fraught with the most in terms of complications, the complications being impotence and urinary dysfunction, including incontinence. So it's a big price to pay, potentially, to get rid of it. But there are also robotic surgeries that are done now, very, very precise, where they're able to do nerve-sparing prostatectomies so that there's a lower incidence of those complications that I've mentioned. And those need to be done by a true expert in the field. And actually, UCSF has one of the best treatment programs around for that, if someone were going to get a surgery for that. So that's treatment of the early stage prostate cancer. Once the horse is out of the barn, it's a different story. Once it's spread into the local lymph nodes or metastasized to the bones, which is a favorite place for it to go, then you're looking at systemic hormonal therapy in the same way we were looking at breast cancer. And here, what's been found is that using drugs that block the effect of testosterone will dramatically slow the growth of the prostate cancer. And those drugs are Lupron, which works on the pituitary gland, and Casodex, which works on the adrenal gland. So by turning off the pituitary's stimulation of the testicles, it shuts down the production of testosterone from the testicles. And by turning off the adrenal gland's production of testosterone, remember adrenals, DHEA, testosterone in women, by shutting that down, it effectively shuts down pretty much all the testosterone production in the body. That's been the standard treatment for a number of years, and Lupron is a hard drug to take if any of you have ever taken it. It causes really significant fatigue, it causes really significant cognitive dysfunction. Casodex isn't quite as difficult, and then also there are chemotherapies that are used, and now there are immunotherapies that are starting to be used, as well as some molecular targeting agents for the metastatic forms of prostate cancer that have gotten very aggressive and spread to other parts of the body. And in spite of that, there are some types of very aggressive prostate cancer that just don't respond well necessarily to anything, and they can be quite painful. But what I've seen over the years is that overall the treatment of prostate cancer has really come of age in allowing men to live longer with fewer negative symptoms, some of the pain and dysfunction that it causes. So, besides the lifestyle intervention, which I also believe is very important, although I disagree with the diet part of Dean Ornish's
In other words,
program.
you're paleo-oriented?
Well, I've been paleo-oriented for a long time, and I'm really shifting towards keto more at this point, ketogenic diet, and we'll go there in a little bit. So for prostate cancer, there's a few things that have turned up over the years that are actually pretty remarkable from the natural field. One of them is the antioxidant lycopene, which is what gives tomatoes its red color. Lycopene is an antioxidant substance that absolutely downregulates the growth of abnormal cells in the prostate cancer cells. There was a landmark study that was done, probably 9 or 10 years ago, where they took men with diagnosed prostate cancer who were all heading for radical prostatectomy surgery, and they put half of them on 20 milligrams of lycopene a day, and the others just did whatever they did. And then they restaged them at the time of surgery and found that the guys who'd been taking lycopene across the board, their prostate glands were much smaller and there was much less cancer involved. It didn't eliminate the cancer, but it clearly had an effect. The other substance that I think most of you probably know about is pomegranate extract. Pomegranate has also a down-regulating effect on prostate cancer cells, and because of that, is being used by many men as a preventative. It's super easy to take lycopene as a supplement, super easy to drink a glass of pomegranate juice or take a pomegranate pill or two a day to get the effect of those substances as well. One other arcane piece of information that I came across a while back in doing some research for a patient was that nitroglycerin, which is used for heart disease, has an effect on nitric oxide, which nitric oxide is instrumental in the genesis of prostate cancer cells. And there was one small study that actually looked at men who had prostate cancer, had been treated, and were then assigned to put on a quarter of a nitroglycerin patch, transdermal patch, for 12 hours a day. And they had a much lower incidence of recurrence than the other group did. Nobody ever followed up on this. I never saw a secondary study to look at this, unfortunately, and doctors want to see, at least a couple of studies from different institutions to confirm that it's right. But, it's cheap at that very low dosage that you get from a quarter of a patch. So at the low dose, it essentially has none of the side effects like hypotension, low blood pressure, or headaches that people get with the traditional doses of nitroglycerin, but it seems to have a salutary effect on helping to treat the cancer. So that was something that I provided to my prostate cancer patients, and I didn't have enough to really gain a clear sense of it, but it seemed like it was helpful. And then I'm trying to be just very specific about these specific kinds of cancers, but the whole rest of the program that we're talking about in terms of diet, supplements, a lot of the anti-cancer supplements, the whole mind-body approach, the community, all of the other, super important. How does one optimize chemotherapy? How does one make it work the best? I've got a couple of tricks that I've learned over the years. One of them, one of our local Marin County practitioners, Michael McCullough, is a licensed acupuncture and also a PhD in public health. And his, part of his personal mission has been to get good information about alternative therapies into the mainstream literature. He authored a paper that was published in JCO, Journal of Clinical Oncology, a few years back, looking at the results of several studies that had been done by others using astragalus alongside of platinum-based chemotherapies for a variety of actually it was for lung cancer. It wasn't for a variety of cancers. And found that across the board, the people who took the Chinese herb astragalus, Huang Qi, at the same time they were on platinum-based therapies did better, had better responses. I was so excited when I read this, and then I asked some of the oncologists that I knew, I said, hey, what'd you think about that? And they go, what article? But they read that journal, but they were just so uninterested in that they just glossed over it. Why would they care about a Chinese herb? So anyway, so that is something, and I think that even though Michael didn't look at it outside of the lung cancer field because he knew what statistically was going to be important was to try to just keep it to one kind of cancer. My belief is that any cancer that's being treated with a platinum-based chemotherapy would do better with the addition of astragalus. And it's a very common herb.
And that article was published in the
JCO,
Journal of the
Clinical Oncology.
Clinical Oncology, right?
Yeah, and it's under his name. You can look under, right. You can search on it that way. Fasting. This is also now in some of the mainstream literature, but it turns out that fasting for 24 hours before chemotherapy actually makes the chemotherapy work better as well. And it may have to do with the fact that the blood sugar is lower in the same way that maybe metformin worked. It has to do with this insulin gate of allowing sugar into the cells. Cancer cells need sugar. Maybe what we're doing at the same time is giving them this cytotoxic, this deadly substance, is that we're also depriving them of their essential nutrients at the same time. But, anymore, and when I'm talking to people who have cancer that are going to get chemotherapy, I advise them to try to fast for 24 hours. They can drink lots of water. They should drink lots of water, but just ramp it down on the nutrition. There is a popular alternative medicine form of treatment called insulin potentiated therapy, IPT. I don't know what to say about this one. I have had patients who've done it who have not really gotten any better. And it's usually done, it's not done by oncologists, it's done by alternative medicine doctors. And the idea is that they give people a big dose of insulin intravenously, usually in a hospital setting where they're monitored so that they can't go into insulin shock from their blood sugar going too low. And then they're given lower doses of chemotherapy. And the idea is it's supposed to work better than regular chemotherapy. There are a number of practitioners who do it. I think that the jury's out. I don't know what to say about it.
Thank you.
Have you had any experience with it?
I don't.
Anne, what about you? Any? Chris? Okay. But you're going to hear it. It comes up. I don't know that I would. At this point, I don't recommend it. I'm also a little nervous about this potential for insulin shock because that can cause brain damage if somebody stays down too long. I really like fish oil. I think that EPA, DHA, the two major components, have significant anti-inflammatory effects. And also DHA, docosahexaenoic acid, is brain food, as I'm sure Anne would love to tell you. She's our brain expert here. And EPA, eicosapentaenoic acid, is significantly anti-inflammatory. These are the two major omega-3 fatty acids that are present in fish oil. They have an immune-building effect, they have an anti-inflammatory effect, and they do have some anti-cancer effect as well. So I think that fish oil supplements are a good addition to our regimen. Now, somebody is wondering, well, why not flaxseed oil? Flaxseed oil is not omega-3 fatty acid. It's alpha-linoleic acid, and it's converted by the body somewhat inefficiently into omega-3 fatty acids. But the ratio of it is about 20-1, which means that if you wanted to get the equivalent of 1 gram of fish oil, 1,000 milligrams, you'd have to take 20 grams of flaxseed oil. So, okay, if somebody is an ardent dyed-in-the-wool vegetarian and they're just not going to have it with the fish oil, knock yourself out, drink a half a bottle of flaxseed oil a day. But otherwise, I would say go for the fish oil. And is fish oil safe? Is a good question. Most of the fish oils on the market now are molecularly distilled, which means that any mercury, PCBs, PBBs, or other harmful chemicals are distilled out before they ever get to market.
What's the dose?
I like to look at about 3 to 5 grams a day, especially if you're dealing with cancer.
The companies that allow third-party testing, third-party independent
Good point.
testing, Nordic Naturals and Metagenics, I really like that they allow the third-party independent testing for mercury, lead, and all the potential chemicals that accumulate in the ocean
Agreed.
and in our fish, unfortunately.
And in the same vein, because mercury can be pro-inflammatory, and sometimes pro-inflammatory can also mean pro-cancer, avoiding the kinds of fish that accumulate mercury is a good idea. Swordfish is probably the highest on that list. Unfortunately, tuna, especially large species tuna, is on the list. King mackerel, grouper, those are the big ones that I remember. Then there's a bunch that are intermediate, like black cod and mahi-mahi. And then the ones that are lowest on the list, salmon tends to be pretty low across the board. And like many other people, I don't recommend farmed salmon. because of the way they feed them, because they're kept in pens. There are probably some forms of Norwegian farmed salmon that are a little bit better, and if you can get those, probably not bad, but otherwise go for wild king salmon when it's available.
And the tiny fish, sardines,
Tiny fish.
anchovies, mackerel,
Right.
the tiny mackerel and the
Right.
herring.
The big predatory fish it moves up the food chain. So as the big fish eats the middle fish eats the little one, the mercury tends to accumulate in the big guys. So for that reason, very small species tuna are probably okay, like bonita. So dietary therapies for cancer. Everybody wants to know, okay, I've had cancer, like what should I eat? What's the safe therapy? The very first dietary therapy I ever heard of for cancer was the Gerson therapy, which started in the 1930s. And it was a diet that was very, very heavy in very sugar-rich juices, vegetable juices, some fruit juices, and also eating cubes of raw liver, which I think was mostly for the vitamin B12 content. And the Gerson therapy is still popular in some parts of the world. Mexico, there are several Gerson clinics. There's one in Southern California. I experimented with it myself when I first got my cancer, and I just really intuitively it didn't feel right. And then the more I started researching and looking like, okay, what's the science behind this? I felt like it really fell flat and didn't really have a lot to offer. We know that sugar feeds cancer cells, and so we started moving more in this direction of, okay, we need a diet that's a low glycemic diet. And the low glycemic diets were also becoming very popular for weight loss and for general health, lowering one's risk of type 2 diabetes, helping to lose weight. So, and glycemic indexes started becoming very popular, where you could download something from the internet that would tell you what the sugar value of a particular food was, and then you could tend to go with foods that were lower on that, lower glycemic foods, less impact on your blood sugar, hopefully lower risk of cancer. Keith Block in Chicago had his own version of the diet, which I always referred to as Midwest macrobiotic. And he and I have been in disagreement with this, but Keith has been macrobiotic for a number of years, and so that's been his bias. But it's a diet that's a little heavier in grains than I would like to see, because all grains have some glycemic load associated with them. I think most of you know quinoa is the lowest on that list. It has the highest percentage of protein, the lowest percentage of carbohydrate, but all the grains can be converted into sugar without too much work by the body. So going on a low grain diet is both anti-inflammatory and potentially anti-cancer. And so that diet more popularly became known as the Paleo Diet. When you eliminate grains and sugars from the diet, what you've got left is protein-rich foods and healthy fats. And that's what a paleo diet is, or Paleolithic diet, because it's felt that that's what our ancestors of thousands of years ago, before we were agricultural based, when we were still hunter-gatherers, that's what their basic diet was. And they would forage and they would eat some plant materials, but the plant materials that they were eating were not cultivated, and they were much richer in naturally occurring alpha-linoleic acid, which the body could convert to some omega-3s. And so for the last several years in my practice, the paleo diet was what I was encouraging people to do for the most part. And most people, once they transitioned over to it, actually liked it and felt pretty good. More recently, we've been looking at the ketogenic diet. The ketogenic diet probably started in the 1960s with the diet doctor in New York. Somebody help me. Atkins. Yes, the Atkins diet, which was a very high-fat diet. Dr. Atkins was promoting this for treatment of cardiovascular disease. And it was absolute, the American Medical Association went crazy on this. Here's an internist who was telling people to eat fat, when the American Heart Association and everybody else knew that fat was what caused heart disease. Well, it turns out that that's not really the case, but back then that was the dominant the dominant idea, dominant thought.
And historically, Ornish's first big debate was with Atkins before the debate came up with the paleo. So there's a historic trend there, Atkins to paleo and Ornish on the low-fat
Right.
side. Yeah,
Right, I know that.
yeah.
But the interesting thing that happened was that Mount Sinai Medical University in New York did a study with the Atkins diet while he was still alive before he died. And they put people on either the Atkins diet, and the Atkins diet, it was a little crazy. He wanted people to eat a lot of fat and protein and just eliminate carbohydrates. And he had people, eating bacon and, full, and saturated, fats from, heavy meats. And it was just full on high fat diet. Anyway, they did this study. Some people on an Atkins, some people on an American Heart Association 30% fat diet, and some people just ate whatever they want. And the only people in that study who had any improvement in their cholesterol levels, weight, and fitness were the people on the Atkins diet. That study obviously didn't go anywhere in terms of the way it changes the dominant paradigm, but it was interesting nevertheless. And then as we started learning about ketogenic diets, ketogenic diets have been popular among performance athletes for actually a few decades, because it looks like the energy that we get from burning and metabolizing fat actually lasts for longer in the body. So that if you're not sprinting, if you're doing an endurance thing, like a marathon run, or a triathlon, or some kind of rowing competition where you're going to be in the water for a few hours, paddling hard, then a ketogenic diet actually optimizes your body composition and gives you enough fuel to be able to get through it better than a high carb diet. So this whole thing about carb loading that people used to do about before events was crazy. You get a short-term burst from carbo loading, but you don't get endurance from it. So ketogenic diets are diets that are very high fat, not necessarily in animal fats. We're looking at healthy fats, olive oil, flaxseed oil, avocados, healthy nuts like almonds and walnuts, and really minimizing, trying to get down to like 7% or less the amount of fat and the amount of carbohydrate in the diet, all carbohydrates, and also trying to reduce the amount of protein. Atkins allowed a lot of protein in the keto diet. It's not, a lot of protein's not allowed. We really want roughly 85 to 90% of the diet to be in the form of fat. I had a little experience experimenting with this last summer. I was on a keto diet for about 9 days, which they say is kind of the induction period where maybe you don't really start feeling very much. But after about the 5th or 6th day, I started to feel a burst in my energy. We were also checking our urine with little strips that measure the amount of ketone bodies in the urine. Ketone bodies are what we produce metabolically when we're eating a high-fat diet, and the urine should start showing a lot of ketones showing up to indicate that you're now in the state called ketosis, which means that you're running mostly on ketones as fuel. Now, one more step back. In the 1950s, some pediatric neurologist, knowing about the brain's ability to metabolize ketones and not needing sugar to survive, looked at kids with untreatable epilepsy and decided that some of those kids might do better by depriving them of sugar and putting them on a high ketone diet. It worked. And every pediatric neurologist knows about this, and a lot of them still use it in addition to the drugs. The drugs have gotten a lot better since then. But nevertheless, you have a way of feeding the brain with ketone bodies, which is one of the reasons why people on ketone diets, the ketogenic diets, feel so good, is because it's good brain, it's really good brain food. Starting about 18 years ago, Mark actually introduced me to a nutritionist who was walking people with central nervous system tumors, specifically glioblastomas, brain tumors, through a nutritionist who was helping people with those kinds of tumors go on ketogenic diets because her partner had developed a glioblastoma. They had gone to the ketogenic diet, and her partner was still alive 5 or 6 years later. And if you know that disease, people usually last a year or two. And so I would periodically have an opportunity to work with patients on ketogenic diets, specifically who had brain tumors, and saw that there was benefit. People seemed to last longer. Now we're starting to look at ketogenic diets across the board for all kinds of cancer. There's not great data out there to support it, but I think that it contains all the benefits of the paleo diet in terms of reducing the sugar, which is kind of major number one issue. But also, if you're flooding the body with ketones, ketones don't feed cancer cells. Sugar feeds cancer cells. And so if you've reduced the amount of sugar and substituted it with ketones, and people are metabolically doing okay with that, then it stands to reason. It's good logic that it's going to have an effect against all other cancers as well.
And as you may have mentioned also, this is something Dwight McKee is very interested in. So, and with all his experience, he's come to the view that the ketogenic diet is a very interesting diet.
Mm-hmm. Yeah.
Yeah, I mean, what's fascinating, because we kind of entered the stream about the same time, is the diet wars have gone on for a really long time. And, when we entered the stream in the early 1970s, where we were and just the evolution of all these different therapies, diet therapies is fascinating. Rebecca Katz's work is on the kind of paleo end of the spectrum. I'm not sure it's on the ketogenic end.
It's not.
Yeah.
Mm-hmm.
I just want to add that the ketogenic diet is a critical piece of the reversal of cognitive decline program.
Great. Oh, that's really
Also,
helpful.
and I also want to say, in case people aren't real familiar with the ketogenic diet, when you look at a plate of food, you can look the plate of food on a ketogenic diet. You can have 3/4 of the plate covered with vegetables. It's not a low vegetable diet, right? Because vegetables are fairly neutral as far as their carb content, because they're high in fiber. So I don't want you to be picturing, you're just drinking cups of olive oil all day, or just nuts and nothing else. It can be a huge variety of vegetables. You add olive oil whenever you can to your vegetables. You cook with avocado oil.
And you have
because
bulletproof coffee for breakfast, right?
Bulletproof coffee, absolutely.
What's bulletproof coffee?
Absolutely, and people can do it without eating very much saturated fat at all. Some people in the who are high risk for Alzheimer's disease carry an ApoE4 gene, and they do not handle saturated fats as well as people who do not carry that gene. And so, some of our, folks who are ApoE4, they put pictures of what they're eating up, and they're on a 70% fat diet, a 75% diet, but their plates of food, it's all vegetables. They just have some nuts added, they have some sardines added, they have, etc. So, just to give a
Great.
picture of it, yeah.
Yeah, a traditional part of the ketogenic diet has become bulletproof coffee in
What
the
is
morning.
that?
It's coffee mixed with coconut oil, MCT oil, which is actually a derivative of coconut, but much higher in medium chain triglycerides, cream, full fat cream, and butter, and blended.
Butter and cream, that's your version, huh? Okay.
That's our version.
Go for it.
And you blend it, and so it turns it into this frothy little amazing concoction that Chris's wife is an expert in making, and I would crawl to their kitchen sometimes for it.
Oh, wonderful.
And coffee is actually, okay, let's talk about coffee for a second. Because coffee has, from the health perspective, has had a bad rap. But in the last few years, what we found is that coffee is actually incredibly beneficial for the liver because it increases bile flow in the same way that we were talking about, how important it is to get the toxins out of the body. So coffee does that. And coffee in the rectum does it with greater efficiency than coffee taken orally. And this is the rationale behind coffee enemas.
Right.
It gets absorbed from the colon, from the large intestine, into the portal vein, which goes directly to the liver, so that the coffee is delivered, 80% of it goes directly to the liver, whereas when you drink coffee, only about 20% of it gets to the liver. And it has this effect of increasing bile flow, probably from the palmitic acid in the coffee.
And coffee enemas used to be in the Merck manual, so it used to be a accepted mainstream therapy.
The coffee also has a substance called chlorogenic acid in it,
Yeah.
which is something that has a tendency to help lower blood sugar
Yeah.
and helps to promote weight loss as well. So coffee has a lot of benefits to it. Now, recently, coffee's been taken to task because of acrylamides that can be present from the processing of the coffee, and acrylamides can be carcinogenic. I don't know what to think about that, but I love coffee so much that I'm tending to shuffle that one aside a little bit. We'll see where that goes, but I think that that's something that needs to be watched. The whole thing with acrylamides in coffee, and of course, in my view, the coffee needs to be organic, and it should probably be light roast instead of dark roast, because the dark roasting we think is what probably increases the amount of acrylamides that are present in it.
But everything that's roasted then, any food that you eat that's roasted, it would seem to me should be then also equally labeled a carcinogen.
right.
Because roasting is what produces the acrylamide.
Right, and when's the last time you walked into a restaurant in California that didn't have a sign on the wall that said, some things produced in this facility may be carcinogenic according to the state of California?
Right.
We've got disclaimers everywhere.
So where do you want to take us next?
I might be pretty close to done at this point. And
Good, because I have some other questions, and
we
then
could
we'll
open
open
it
it
to
up.
questions. Okay.
Question about supplements. We all know that the supplement industry is unregulated, and that when you do careful testing of supplements, a lot of them don't contain what they say they contain. The markups are often very high, all kinds of problems. What is your guidance to patients, or for that matter, practitioners, on the brands you trust or the approach you trust to getting high quality supplements?
Oh boy, it's been kind of a trial and error
Yeah.
and seat of the pants
Right.
decision over the years,
Yeah.
because as part of my practice, we also had a natural remedies store.
Right.
So we were selling product, and some people would think that that's a conflict of interest, but in my view, it was a way of providing things to people that we had vetted and knew
Right.
about.
Right.
Over the years, the companies that I grew to trust were Allergy Research Group, which has been around for a long time, Metagenics, Designs for Health,
Pure encapsulations.
It just got bought by Nestle, so we'll see what
Oh,
Wow.
What? Oh, they got bought.
Pure got bought by
just-
Nestle's?
Yeah, this was like 2 weeks ago.
Nestle, right? Yeah, that's not
There's,
good.
yeah, trustworthy.
Well, I have a small investment in a company that has a natural way of accelerating the growth of tree seedlings into hardy plants ready, for agriculture. That now is focused on the cocoa industry and has, several contracts with companies in Ghana, which is a very big cocoa growing industry. And I just got a newsletter from them talking about how the cocoa growing industry is really very environmentally unsound overall. Is destroying vital nutrients in the lands. Is really creating wholesale agricultural problems, and the demand for chocolate worldwide is so huge that they can hardly meet the supply. So they're just they're being irresponsible. And the company was sending this out to just because they wanted people to know, and they included a link to a website that shows the companies that have that have already signed off on using environmentally sustainable practices.
Right.
So in other words, they'll only buy their cocoa from growers that they know are using environmentally sustainable practices. And believe it or not, Nestle's was on the top of that list. Blew my mind. The people who were robbing kids of breast milk. But anyway, I'm happy to pass that on to you, and you can send it out.
Okay.
To that link. It's very interesting.
So your response is that it was trial and error, and that your practice ended up with a supplement store that represented the things that you had found.
Yeah.
And then that
Vitanica is another good company, Vitanaca.
Okay.
Oh
So
my
it's
gosh,
a that's something I mean, I've been thinking about this for years, but it's such an issue for people spending a lot of money on
Yeah.
supplements to be sure they're getting
And
what
I
they
actually
have.
went to the Metagenics plant one year to visit it. I wanted to see how are they doing this, and had a tour through the plant. I was very, you weren't on that one, you didn't go. I was very impressed with it. I felt like their quality control was excellent. Their standards for sterility, looking to make sure that what was supposed to be in the product was in the product when they did aftermarket testing, pulling stuff off the shelves and of their own stuff in the markets. So I looked at that with Metagenics. They're a high-end company. They're expensive, and often the quality supplements are from higher-end companies. So if people are trying to save money by buying something at CVS, that's a CVS brand of some vitamin or other, I'm not sure I would trust it.
No, absolutely, absolutely.
If that's somebody's only option because they
Right.
can't afford it otherwise, yeah.
So if we step back, and first of all, thank you for this list of specifics. And if we step back from the specifics, patients trying to figure out who to see, where to go. The mainstream oncology, as you say, my brother is acting chair of the Department of Oncology Hematology at BU, so I have a tremendous respect for mainstream oncology. But as you point out, it's often overused, and people just don't know about both the integrative end of this and the overlooked novel therapies, however we want to describe them, the metformins and so forth of this world. So how are we going to make progress on this? I mean, we've identified the naturopathic oncologists as a resource, right? That, that, as you said, you came to have a naturopathic flavor or whatever to your practice. And Chris is a naturopath. But given what's happening to the individual integrative oncologists like Keith Blocks, who faces these challenges that, on facing more expensive costs for chemo and so on than somebody who's part of one of the big chains and everything else. Where are the practitioners? Where do people find the practitioners? And who are the people who do what you and Keith are doing in terms of guiding people? Now as you know, there was this year at Commonweal, one of Mark Renneker's conferences, which you were at, he completed the training of a whole set of new guides, and that group of guides asked if they could become a project of Commonweal, which we're calling the Commonweal Medical Advocacy Collaborative. And so we've just begun to make that available to people as a way to find guides. But that's just a very tiny fraction of the need. So when you think about how today and how in the future we can move this truly vital field forward, what do you think? How do you look at it?
I tend to stay in the trenches
Right.
with it. And in terms of trying to go larger scale, I made a few forays into that. I think you remember I was the medical director of Consensus Health, and we had a very big, we had a very aggressive stance on trying to get the information out about alternative cancer therapies through a very large website, and also working with insurance companies to try to get them to pay for alternative therapies. And we started to gain a little traction, and then it all collapsed. Taking the step of formalizing the medical advocacy training, which I helped Mark with,
Yeah.
so that we now have a fairly good
That's
sized
right.
group
You're
of
one of the
doctors.
senior staff with Mark.
Yeah.
Yeah.
So doing that's a move in that direction for
Yeah.
us. Before that, Mark trained a handful of us
Right.
to do the same kind of work, and we would all be kind of overloaded because people, Mark has a 6-month waiting list.
Yeah.
He's got people calling him with stage 4 cancer. He feels terrible about it. And so we now have a group of people trained. He tried to get UCSF involved in that. They wouldn't have it. So he said, well, I'll call Michael and see if Michael can host us. And,
Yeah.
and here we were. And it's been really rewarding. They've got the skills now to be able to do the advocacy work. They still have communication and availability to Mark and the other mentors. And we actually are having a meeting tomorrow at my house of the whole mentorship group. We get together monthly, and when I'm out on my sailboat somewhere in the South Pacific, I call in and I'm the guy on the phone with the rest of the group.
Oh, that's very reassuring.
Yeah.
Yeah.
So I would think that trying to use that as a template and expanding from that somehow to get more doctors trained. A true, rigorous training program really needs a university, behind it for the infrastructure and stuff. And just, I don't know, maybe that'll happen, maybe it won't. Eric Jameson, who Eric is.
Yeah.
Eric has been very instrumental in handling a lot of the administrative aspects of it. Because Mark's more of kind of the visionary. And says, we ought to do this. And everybody goes, oh, that's a great idea, let's do it. So I think that's the way I see it. It's just going to be kind of growing from this seed and trying to expand out, as more people learn about it.
Yeah. Chris, I want to come back to you. You've been listening to all of this and commenting, but what would you add to this in terms of your experience and perception of the work?
Yeah, I think, as a naturopathic doctor, we've been trained to look at the cause. And I feel like the conventional world doesn't really look well at the fact that we're living in a toxic soup of chemicals in us. And so we're the handful of doctors that will actually do toxicology testing of the most common things that we can cheaply test for. And I always find a bunch of high level 95th centile carcinogens in my patients, different sets. Some of them follow different patterns based on what type of cancer they've got. And I also think that the cancer comes back if you leave those chemicals in people. So that's kind of a little bit of a different take on this that we come from.
You were involved with the response to the fires in Sonoma County, the vast fires that wiped out so many thousands of homes. Actually, my wife, Cheryl Patton, has been testing the frontline firefighters for their levels of chemicals. She tested 200 firefighters, control group of 100, and another 100 who were on the front lines. So, and Kira Epstein has been coordinating the conversations that we've done in Sonoma through the new school, which I know you've been part of. So, have you been working with a lot of people who had those exposures in the fires?
Absolutely. The way we look at an event like that is you're now exposed to a lot of carcinogens, burning petroleum, burning plastics, burning metals, and we thought it to be prudent to teach the population how to detox rapidly. And Peter Koshland from Koshland Pharmacy was kind enough to send us about $10,000 worth of glutathione that we treated people for free with. My wife, as well as a woman named Jenny Haro, organized a massive push to get practitioners in every fire station, every shelter, every National Guard unit during those times. So for about 3 weeks after, I was with mostly in Petaluma, but also in Santa Rosa at the National Guard units. So I was working with search and rescue and making sure that they understood the toxic exposure that they had and that they seeked out appropriate treatment. I don't want to wait 10 years till these guys get cancer. I want to get it out now. So that's kind of the way we look at things.
You know, this is an interesting story, but right after 9/11, I went back to New York while the buildings were still smoking and everything. Mm-hmm. And I've had an interest in detox for a long time. And one of the members of one of our listservs was a guy who was expert on a lot of tox stuff. And he was a Scientologist, right? Well, I don't have any brief for Scientology, but they had set up a clinic in Manhattan just below the 9/11 site where they were treating a lot of first responders. And the first responders they were treating had gone to mainstream medicine, been, pumped up on different things, but nobody was doing detox. So I walked into this clinic, and it was extraordinary. They had all these guys with a detox regimen, and then doing saunas and working out on bicycles. And they had the towels that they had toweled off with from the sweat, and you could see these rainbow of chemical colors on the towels, So I entered into a conversation with them. Of course, they did not want to say that Scientologists had been involved in setting up the clinic. They happened to be Scientologists and so on. And I encouraged them to do a real clinical trial, and they were not interested in doing that. But I've known people who've gone to independent physicians who trained in the Scientology system of detox, who've had really exceptional responses. And the Scientologists themselves have done an extraordinary review of the world literature on detox with a lot of studies from the Soviet Union and elsewhere. So, as I say, I have no brief either for or against Scientology. Bless people who like it, bless people who don't. But the detox stuff that they've done seemed to me to be a contribution to the field.
The purification rundown.
Excuse me?
The purification rundown.
Yeah.
I did it in the 80s.
Oh, you did?
Yeah, and it was the best I've ever felt. I mean, at that time of my life.
Interesting.
But
Yeah.
I went through the whole thing.
Yeah.
I'm in Scientology
Yeah.
for some time, but I have to say, of all the different things that I didn't like about Scientology, that was the one thing that I thought was that stuck.
Anybody?
Michael, what were they doing? I
Yeah,
mean, it sounds
what
like they
were
were
they
doing
doing?
sauna, but what was their detox?
They had a. Does anybody know this better than I do?
I do.
Yeah. What did they
I'm
do?
sorry.
Yeah.
They do exercise,
Yeah.
sweating in saunas.
Yeah.
What Hubbard called CalMag. Basically, it was a cider vinegar mixed with calcium, magnesium, and some oil. You drank a lot of oil, and you would have this before you go every day to the sauna regimen, and we would sit in the sauna and sweat, and we'd run, and we'd come back and we'd drink lots of water and take our CalMag, and it just kind of makes sense.
That's awesome.
That you're replacing the
Similar to what we
fats.
do.
The idea was to replace the fats that you were getting rid of and putting lots of extra fat in your body. And of all the different things that were pretty weird about Scientology, that was one of the things that I thought really made sense. And I felt I was in my early mid-20s, but I felt really great.
Chris,
The
did
high
you say?
fat will increase the bile flow, which will
Yeah.
increase the colon clean out
Yeah.
part of it.
Also, fat-soluble toxins will go to that fat gradient as well.
Right.
Yeah. It's just an interesting piece of the.
Yeah.
What I'd love to do is get my hands on the multi-volume set of studies of the world literature on detox that I saw on their shelf in this at this clinic. But it was striking. And again, we are living in this incredibly toxic world. That has been a big part of our work at Commonweal. Dr. Ted Shetler, the head of the medical director of the Collaborative on Health and the Environment and the Science and Environmental Health Network, which is here, and a longtime colleague, has been a deep part of that work. And actually, let me take a moment to introduce Ted. And Ted, could you just say a word, because it's so relevant to this, about your book, The Ecology of Breast Cancer, and your basic thesis about the ecological paradigm of health?
Sure, thanks. My background is in medicine, but also in public and environmental health. And my work has been an attempt to sort of reintegrate medicine with public and environmental health, because they've been so separated for the last 100 years for reasons that we all sort of understand. So when I began thinking about breast cancer and the origins of breast cancer, with an aim towards thinking about prevention, it became apparent to me that there are some countries that have low incidence of breast cancer compared to others. As they westernize in their development, breast cancer increases. When people move from countries with low breast cancer incidence to countries with high breast cancer incidence, their risk of breast cancer goes up. And if you look across these observations, you can't point to one or two things that explain that, but rather it's sort of an ecological shift. Lots of things change. The chemicals that we've been talking about, diets change, activity levels change, social interactions change, and these aren't only at the individual level, but they're also at the community level and at the societal level. So it seemed to me that bringing ecological thinking to those observations might be useful. And what I mean by that is that, ecologists think about the behavior of an ecological system in ways that are very different from the ways that in reductionist medicine we tend to think about causes of disease. Patterns of disease emerge out of ecological conditions. And so if we're going to think about the prevention of something like breast cancer, it seemed to me that we need to think about a multifactorial approach that was also at a multiple level approach. Not only what can we do as individuals, but what can we do as communities and as societies to try to shift the system conditions that are leading to the disease patterns that we see. And it's not just breast cancer, because other common diseases emerge along with breast cancer at the same time. And so to think about it across time, across the life course as well. So I was very interested, Brian, when you were talking earlier today about epigenetics and about how chemicals or dietary factors can influence the expression of genes. And I was reminded of a very recent paper that was published just very recently, showing that DDT in the serum levels are correlated with the epigenetic markers on the BRCA gene, the BRCA gene.
So that's the connection.
So, pardon me?
That's the connection,
That's
because we've always known that DDT was a risk factor.
So DDT in adulthood levels, the evidence was mixed about whether it was linked to breast cancer. But recent studies have shown that higher levels of DDT exposure in utero and in childhood are associated with a much higher risk of breast cancer decades later. But now we know something about a potential mechanism, because the DDT in utero was putting an epigenetic marker on the BRCA gene, even if it was a normal BRCA gene, not a mutated BRCA gene, but a normal BRCA gene, turning it off so that the DNA repair mechanism in the babies and in their lives to follow was not working as well because of this in utero exposure. So this is a design problem. This is a societal problem. I mean, these people weren't purposefully exposing themselves to DDT. We put it into our food. We put it into the environment.
I used to ride my bicycle behind the DDT truck spraying for mosquitoes in my town. That was fun.
Right. Yeah. So anyway, thinking about the mixture of the medical approach and the public health approach, I think sort of opens up some ideas about how we might begin to think about prevention and conceivably treatment at societal levels as well as individual levels.
Great.
So they're complementary.
Great. Thank you.
I'd just like to build on that for a moment, because Ted's thinking about the ecology of health has been fundamental to what we've been working on through the Collaborative on Health and the Environment, which is www.healthandenvironment.org, for the last 20 years, so that taking an ecological approach to health, as he was just talking about with breast cancer, is fundamental to us. And so what fascinates me is that if you take an ecological approach to health and you ask what form of medicine fits with the ecological paradigm of health, guess what? It's not reductive Western medicine. What it fits with is integrative medicine, functional medicine, naturopathic medicine, because the bottom line ideologically is that different people get the same disease for different reasons. They come into it from different pathways that converge into common pathways. So if different people have gotten breast cancer or asthma or learning disabilities or whatever it is for different reasons, then insomuch as etiology remains relevant, you wouldn't expect everybody to respond to the same treatment. Guess what? You would want to try to figure out which etiological pathways they came in on, and therefore which potential stressors were most relevant. So just coming back to the starting of Commonweal, which we did together, Commonweal started with a vision of healing ourselves and healing the earth. And it's very hard to be healthy people on a sick planet. And the reality of the situation is that for all the activism that so many of us have been involved with for the last 30 or 40 years, the planet is getting sicker. And in fact, the people who really look at this, and I've been looking at it in depth, if you want to take a look at the faninitiative.net, you look at the global challenges that are going on. The scientists who are looking at this in depth, Paul Ehrlich from Stanford and others, really believe that there's a very good chance that we're headed for a civilizational collapse in another 20 or 30 years. I mean, just the stressors are just increasing. You know, climate, toxic chemicals, how many crop years are left on food, foods, population. There's at least a dozen, you could count 20 different major stressors. And those same stressors on the earth as a whole, biodiversity loss higher than it's ever been since the end of the age of dinosaurs. So there's this tremendous loss in biodiversity. Guess what? That converts into the loss of biodiversity in our gut biomes and everything else. So the medicine for the individual and the medicine for the planet are essentially the same medicines at a deep level, And so what we're really struggling with as we think about how we're trying to bring this integrative, functional, naturopathic medical paradigm back in, along with all the benefits of good technological medicine, is the medicine we need for the planet as well, So this is very profound stuff, And so the fight is against high odds, is a fight for the future of the earth and the future of human health and the health of nature. So it all fits together in a really fundamental way. And it's no surprise that it's hard to be healthy people on a sick planet, So. Brian, any last thoughts or comments as we enter our last 10 minutes of the conversation?
Actually, as you were speaking just now, I was thinking about the Malthusian theory of overpopulation and where we're headed with that and how that's converging with this thing about lack of biodiversity.
Yeah, right.
It's kind of bad news.
It is kind of bad news.
It's bad news. And that combined with the fact that, with our current political situation, that we don't have leaders that are thoughtful and proactive in terms of helping with that at all. So, how do we work at larger levels? I'm a little bit at a loss for that. As I said, I just tend to work from the small to slowly expanding, hoping that works to some degree. I would encourage people who are dealing with cancer diagnoses to not limit their care to just the conventional oncologist, but to seek out and find a skilled practitioner of natural medicine, and that person should also be open to the mainstream treatments and supportive of them as long as they're appropriate for the condition. But really working with a combined approach like that is really what's likely to get people the best outcome. Yeah.
What is, pursuant to that, what is your wisdom around finding that practitioner? It's a little, when you dive into the data and the research and get all the recommendations from your friends, it's a little overwhelming, other than sort of waiting for that person to walk through your door. So in your experience as a clinician, what advice can you give us?
Right, so if you're looking, there are a lot of general oncologists around who will take on pretty much all kinds of cancer to treat. And then there are some who specialize. There's some who really just want to work with breast or just want to work with, gastrointestinal cancers or colon cancer. what makes sense is to, and sometimes you need to travel. Sometimes you can't stay in your local home community. You've got, I mean, in my case, I wound up going to MD Anderson to get the definitive opinion on what I should do, and that worked really well for me. I've sent patients as far as New York or Florida for specific practitioners because of my knowledge of the network. And so an advocate is somebody who can help you find the right practitioner. Michael just mentioned this advocacy training program that we've had going on. It's just come up on its second year of its inception. What that means is that we've got about 8 or 9 doctors now who have gone through the program who can help anybody with any type of condition, whether it's cancer or other, be able to try to start mapping out the right route, which includes finding the right practitioners for their condition. So I would say that that's probably the best way to go at this point.
Yeah. Any other questions, comments? Yeah.
It sort of maybe feels like left field, but I'm curious, hyperthermia has been coming up a lot for me recently. People have been mentioning it as a treatment. I believe it's mostly approved in conjunction with chemo or radiation in the US. But I wondered if you've heard about it, if you have any opinions about it.
So most of the hyperthermia work was done in Germany, and there are still clinics there that specialize in it. I have not been impressed with it as a treatment mode.
Mm-hmm.
That's my bottom line on it.
Yeah. Yeah.
You were going to touch base on cannabis.
Oh
Do you
yeah,
have
we
time to
forgot
do that?
cannabis. Yeah, do you have some?
Not on me.
We. Well, California is a great place to be now if you want to, for cannabis. But
So is Washington.
I mean, starting probably 15 years ago, we started getting some inklings that CBD, cannabidiol, CBD, which is one component of the marijuana plant, seemed to have some anti-cancer effects. And the first mainstream research was done on rats with experimental brain tumors, and it really seemed to work. Since then, there has not been a lot of mainstream research. Donald Abrams, who's one of the people, did he get into this much in his talk?
Yes.
Okay, good.
Yeah.
So,
But I mean, please repeat what you want to say.
Don's had so much more experience with this than I have. But I would say that CBD in its various forms and strengths does have an anti-cancer effect, and it's also very beneficial for dealing with some of the side effects of chemotherapy. Some of the depression, certainly the nausea and vomiting, some of the pain.
Yeah.
I think it's a very, very, very important, useful adjunct in cancer treatment.
And safe.
And very safe. And and even people who are long-term marijuana smokers, interestingly, do not have an increased incidence of pulmonary disease, including lung cancer, chronic bronchitis, all that. You would think that they would, but they don't. And they think that, part of the reason that they don't have an increased incidence of lung cancer is because of the anti-cancer effect in the cannabidiol that's blocking any of the irritating effect on the bronchial mucosa that could potentially trigger, cancer cell growth. So, yeah, I'm a proponent of it. I think that there are CBD tinctures and extracts that are available at the marijuana dispensaries now that have, a lot of usefulness. Most of the dispensaries, the people that work there have a pretty good idea about, what's good and what's not. Did Don get to cover some of that in his talk?
He didn't talk too much about the specifics of dispensaries, no.
Or about what specific substances to use in the setting of
No,
cancer?
he didn't talk about that.
He didn't go there,
no.
yeah. And I don't consider myself an expert on that at all. I would usually turn people over to someone in the dispensary who I knew had pretty good knowledge of it. But some of the extracts are really good for sleep and anxiety. Some of them have more potent anti-inflammatory, anti-cancer effects, but they definitely have I'm sorry we left that out, very important place in the treatment of cancer. Thanks for bringing that up.
There is a cancer specialist at one of the dispensaries in the Castro. I think her name is Sarah Patton.
Great.
And my Kaiser oncologist referred me to her,
Lovely.
which was wonderful. So
That's great.
I'm going to meet with her in a couple of weeks.
And I just heard about a nurses collective in somewhere in the Bay Area, I think maybe in the East Bay, of nurses who've been specifically studying cannabis use in various conditions, including cancer, and can meet with individual patients to look at what's going on with them and make specific recommendations on what to use, what strength, how often, et cetera. Because dosing is always an issue as well.
Are there any treatments specific to neuroendocrine cancers that you can share?
Yeah, there is one. And I don't know how available it is in this country now, but it's called MIBG. And it is a radioactive substance that's bonded to the norepinephrine molecule, which neuroendocrine cancer cells accumulate. And so it's a smart bomb. It's given by intravenous administration. It tends to go to the neuroendocrine cells, lock onto them with a lethal radiation dose, but that radiation is in microparticles and doesn't affect much of the rest of the body. Duke was doing this 6 or 7 years ago. They had to stop doing it because the American supplier of the MIBG substance wasn't making enough money and stopped making it available. The last time I looked at this was, several years ago, but Royal George Hospital in London was making it available and doing it.
There's a neuroendocrine clinic in Kenner, Louisiana. There's a Dr. Campos that was doing that years ago.
Oh, great. I didn't know about that. So that might be something to follow up on. Great. Good tip.
Anybody else? Yeah.
To circle back around to the anti-angiogenesis, do you have any thoughts about using zinc for that? There was something, I think, out of Mayo about it being effective even in lymphoma, which of course we don't think of as there being a tumor to cut blood supply to. So I'm wondering about your experience with zinc
I actually don't know anything about zinc as an anti-angiogenic agent. That's the first I've actually heard of it. It's quite possible that it has anti-angiogenic properties, but
sort of
I just don't
not
know.
blocking, but
It competes with copper for transport, so I
exactly.
could see.
Okay, that's the link. And part of that whole copper chelation protocol that we use is using the drug tetrathiomolybdate and also a low copper diet, and also using zinc to help to replace some of the copper, because they do that switch like sodium and potassium do. Okay, thank you.
Yeah.
Subject real quick. Somebody suggested for me, I think, molybdenum or something like that as a copper chelator. Do you know?
No, it has to be the other one. It has to be tetrathiomolybdate. And actually, N-acetylcysteine, which is a natural supplement, also has some copper chelating properties as well. So it's one of the natural things that can be used along with that. N-acetyl, A-C-E-T-Y-L, cysteine, C-Y-S-T-E-I-N-E.
Chris, did you have another comment?
No.
Okay. Brian Bouch, thank you with all my heart for coming back to Commonweal and for being with us at the New School.
It's always a
been
pleasure,
just
Michael. Thank you.
Wonderful.
Thank you.
So,